Okay. Good evening, everyone, and welcome to another webinar. And tonight we've got a really exciting speaker, and our chair is Andy Johnston, who is on the board of Sarcoma Foundation New Zealand and one of our orthopaedic surgeons. Lots been happening recently in Sarcoma Foundation, so stay posted and I'll give some updates at the end. But for now, I'll hand over to our chair, Andy Johnston, who can introduce our wonderful speaker tonight.
Thanks everyone, and thanks for joining. Tonight we've got Karen Billington, who is one of our tumour radiology experts at Auckland City Hospital in the North Island Sarcoma Service, and at Auckland Radiology Group in Auckland. Karen went through medical school in Trinity College in Ireland, and then did all her radiology training there before coming to New Zealand to do a radiology MSK or musculoskeletal fellowship, and then decided to stay on afterwards. And we're very lucky to have her as part of our North Island Sarcoma Service. So without further ado, I will hand over to Karen to give her presentation. Just a reminder, as always, that if you've got questions, stick them in the Q&A section, and I'll ask them for everyone at the end. Thanks very much, and over to you, Karen.
Thank you very much, Andy. So I'm just going to share this now. Just let me know if it's all good.
Yep.
Okay, great. So just tonight, just going to be discussing the role of the radiologist in the sarcoma service, who we are, and what we do. So this is probably the most common question I get asked when I say I'm a radiologist. Do you take x-rays? So just to clarify, there's lots of different terms for jobs that sound very similar, and we all work very closely together. So a radiographer is somebody who takes the images. So they will operate the CT scanner, the X-ray machine, the MRI machine, and then I, as the radiologist, will then interpret the images. And then a radiation oncologist will then treat any tumors with radiation. So three very similar terms doing very different jobs, but all working very closely together. So I'm the middle one in here. So the radiologist, we, like Andy said, we're medical doctors. So we do our medical training. We spend usually a few years on the wards, and then we do our specialty training in radiology, and then our subspecialty training, which in my case was MSK, so musculoskeletal. And so what we're trained to do is basically to recognize imaging patterns of disease. So what we want to do is when we look at a scan, we'll see different findings. And then just through experience and through obviously a lot of study, we learn to recognize patterns of disease. So we see a particular finding in the liver, another particular finding in the pelvis, and we're able to basically put them together and work out what's going on. We do that in conjunction with knowing your clinical history, your blood tests, and any previous imaging. And when we talk about Ant-Mini, so that sometimes comes up for bone lesions. And the phrase in radiology is if you're trying to describe to somebody, someone that you know across the room in a crowded room, and you're trying to pick out this woman who's your Aunt Minnie, and how would you get that other person to recognize them? It's just something, you could say they have brown hair, blue eyes, but they're not going to be able to pick her out because they don't know her. So it's like, how do you know your Aunt Minnie? Because that's what Aunt Minnie looks like. And that's what radiology sometimes comes down to, just years of experience, seeing tumors, seeing bone lesions, and something becomes Aunt Minnie. We just know that that's what it looks like. So with my job in musculoskeletal radiology, my particular interest, not only sarcoma, but also sports imaging and rheumatology. So our role in the sarcoma service, there's a couple of different things that we do. There's myself and a group of 5 others. So obviously their number one job would be to report the scans. So if you have your scan at Auckland Hospital or at ARG, I will be reporting your x-rays, your ultrasound, your CT, PET-CT, MRI. But as the North Island Sarcoma Service, obviously we see patients from all around the North Island. You may not have had your imaging at Auckland. And so what happens is that gets sent onto our system, and then we will also review all of these external scans. So we will have a look for any scans you've had. So we have a system where we can search You don't have to remember where you've had the scans done. We will search them and we will bring them all onto our hospital system to make sure we get the full picture, get as much information as we can, compare all the scans to try and get as clear a picture of what's going on. Once we have all that information, then we will present those scans at the MDM. So with Andy and Joe present, along with the radiation oncologists and the specialist nurses. And what the idea there is that we present the imaging, and they will present the clinical history, and then we basically try and come up with either a biopsy plan or a treatment plan of where to go and make sure that everybody is on the same page. And then the other thing that we do, and maybe people don't realize, is we perform a lot of the biopsies as part of the sarcoma service. The reason being, a lot of them back a while ago used to be done surgically. So it was a much bigger procedure. It required a bed in the hospital. It required a general anesthetic and a lot of resources. By doing it with radiology, and I'll be discussing it a little bit later, they're minimally invasive, much quicker recovery time, same day outpatient procedure. And then the other thing that's becoming a bigger and bigger part of our job is minimally invasive treatment of some bone lesions. It's not in relation to sarcoma, so I'm not going to go into it this evening, but that is an evolving area of our job. But with that said, so you've got so many images, where do you start? So I think most patients present with a lump or with pain. So for us as a radiologist, even though we have access to lots of fancy scans, MRI, PET-CT, honestly, for us, X-rays are the first port of call. We always start with the basics. So for us, it's really helpful to see the pattern of a bone lesion on an X-ray, because again, they can have that mini appearance, but also very quick to perform, widely available to GPs, physios, osteopaths. And what we're looking for on the X-ray, so we look at a bone and we're looking for lucency and sclerosis. And what we mean by that is basically areas that look less dense or more dense than normal bone. And that might indicate that there's a lesion in the bone. The other thing we look for is what's called periosteal reaction. And what that basically means is it's bone formation, so new bone setting down around the existing bone in a response to abnormal stress. Now, again, it doesn't necessarily mean that there is a tumor in the bone, but just some kind of a stress. So it could be a fracture, it could be infection, or it could be a bone lesion. And that's really well demonstrated with X-ray if it's been there for a while. And then the other thing that X-ray is excellent for is soft tissue calcification. So we actually really struggle to see soft tissue calcification on MRI. So having an X-ray, when we're reporting the MRI, if it shows calcification, it really helps us with narrowing down what we think the diagnosis might be. The other thing to think of is that a bone lesion can often be an incidental finding. And what that means is basically you might be getting the X-ray for a totally unrelated reason. Commonly, maybe you've sprained your ankle. You're getting an ankle X-ray, and then the radiologist notes that there is a lesion there as well. So that is really important part of our job, that we don't just address the question that is being asked, that we make sure we're looking at everything in the image, making sure that we're not missing anything. And then the other important take home from an X-ray is that a normal X-ray does not exclude a tumor. So if your X-ray is normal, but you still have pain or you still have a swelling, it needs to be taken further. So it's just to remember that. So this is just a conglomerate, very complicated looking image, but it's just to give you an idea of the spectrum of appearances of different bone lesions on an X-ray. Many of these are aggressive, some of them are not as aggressive. So when we go back to the previous slide, when I was saying about lucency and sclerosis, so this is lucency where the bone looks less dense than normal. And this is also lucent. When we talk about sclerosis, where it's more dense, this would be sclerosis here, here, and here. So again, we spend years and years training to see all these different lesions and learn to recognize them. Now, it's lovely when the lesion ticks all the boxes, has the classic appearances, not always the case. So sometimes we can say, well, there's a lesion there, but we're not quite sure what it is yet. In this case, we take it further with extra imaging. So this is an X-ray of a wrist. And what it's showing here is calcification in the soft tissues. along the inside of the wrist. So this would be kind of difficult to see on an MRI. But this pattern of calcification to a radiologist, this immediately tells me this isn't just soft tissue calcification, this is phleboliths. And therefore, what this swelling is here is almost certainly going to be a benign vascular tumor called a hemangioma. So we can make that call from an X-ray by getting just this information about the soft tissue calcification. So the important thing is just not to dismiss the importance of having an X-ray. And then this is periosteal reaction. So again, this is a bit of a detailed slide, but it's just to indicate that there is a lot of different types of periosteal reaction. And as we go through our training, we learn to try and recognize the different types of reaction. So we talk about being non-aggressive and aggressive, as opposed to being benign and malignant, because infection, while it is benign, is also aggressive. So things like a healing fracture will give you this non-aggressive periosteal. It's a healing response, whereas something like a sarcoma might give you something more aggressive looking and irregular. And we'll just show you this now in an X-ray. And when you think about the process undergoing what's happening in the bone, it'll start to make a little bit more sense. It might be a little bit difficult to appreciate, but there's just this linear line along the outside of the bone, which is really smooth along here. So what periosteal reaction is, we said it's new bone formation. And if you think about the bone trying to heal, if there's something non-aggressive, it's slow growing. So the bone has time to lay down in a smooth layer. But if you have something where the bone is being damaged very quickly, and the bone is not getting a chance to heal in an appropriate amount of time, it's just laying down this periosteal reaction in a very haphazard way. And this isn't getting a time to form into nice, smooth layers. So that's why we see this being more aggressive. And it suggests that there's something underlying it that's behaving in a very heterogeneous, irregular manner. So then ultrasound. So ultrasound and X-ray often go hand in hand as sort of the first port of call in sarcoma, because many patients will present with a palpable lump. So again, it's widely available in the community via GPs and physios. Can be incidental, but not as much. So most patients are coming in saying, I have a new lump, or I have a lump and it's increasing in size. It has no radiation associated with it. And it's really good for soft tissue lesions, but particularly those that are superficial, okay? So if you go back and watch the retroperitoneal sarcoma talk with Carla, she talks about the sarcomas that are deep in the back of the abdomen. So ultrasound isn't very good for those because it's based on a beam coming from the ultrasound probe into the body and back to the beam. And the further the beam has to travel, the weaker it gets. So it's really good for the lumps close to the surface, not so good for something deep down. But the main role of ultrasound is to distinguish between something that is cystic, made of fluid, or something that is solid, okay? It's not always diagnostic. That's a key thing to remember. The ultrasound may not give you the answer. It might, and we'll have a look at a couple of cases. But the idea is that it's to help guide further imaging. So for example, if we see something in the outpatient ultrasound list and it's a palpable lump and we image it and it looks really cystic, no concerning features, we can write back to the GP, we're happy, it's a cyst, don't worry. If we see something solid, it's got some blood flow to it, it looks a bit irregular, then we know to expedite it. And we will say at the bottom of the report, please consider referral to the sarcoma service. We need a specialist opinion and maybe an MRI. And the other thing that an ultrasound has a really important role in is it's used to guide biopsy. And we'll come on to that a little bit later. So you've had your x-rays. Oh, sorry, we'll go back to this first one actually. Sorry, so this is an ultrasound here. So this is the surface of a finger. So this is the tendon here. And then this is the lesion here. So the patient comes in with a palpable lump on their finger. So what we can see is that it's really, really well defined. It's got a really clear margin. So they always say if you can take the tip of a pencil and draw around it, then it's very well defined. And what we can see is it's very black. And so on ultrasound, the fluid is black. And you can see this white behind it. So the beam is passing through the fluid and appearing brighter behind it. So that tells us it's very simple fluid. So we know from this ultrasound that it's a simple ganglion and it doesn't need any further investigation. And then we have a look at this lesion here. So again, it looks dark, but it's not quite black. Okay, so we can see little areas of gray in it. So this is solid. But we can also see it's got this sort of tubular structure coming out of either end of it. And when we check with the blood flow, there is a little bit of blood flow. And this has the classic appearance of what we call a ball on a string. And this is a nerve sheath tumor. And this appearance here, this looks like a very benign one. They do have a potential to transform, but when they look like this, very well defined, very homogeneous and smooth, it's a benign peripheral nerve sheath tumor. And this lesion here, this is a really common one that we see. So you can see this looks totally different. Okay, so it's much lighter gray. So we can see the capsule just around the edge just here. It doesn't look as simple and homogeneous as these other lesions. It does look a little bit heterogeneous. However, it does look very similar in its shade of gray to the tissue around it. So when you look at ultrasound, you've got the skin right at the top, and then we have our subcutaneous fat. So we're looking at this lesion and going, well, it looks very similar to the fat that we're seeing all around it. It doesn't have any cystic bits. It doesn't have any parts that don't look like fat. So therefore, it's a lipoma. So these would be three very common benign lesions that we would see with ultrasound. And we would have a high degree of confidence in saying this is all that's needed to be done. We don't need to do anything further. But then we get to the question of what if X-rays and ultrasound haven't answered your question? And this is when it's time for referral to the specialist. And I thought this was just a lovely picture of Andy to include. So this is when we send referral to the sarcoma service. So we will put at the end of our report, refer to the sarcoma service, consideration for further imaging. So first port of call for any imaging of bone tumors and soft tissue sarcomas is MRI. So just as a reminder, this is kind of what the MRI looks like. And many of you may have already had one. So it is a very large magnet and there's a narrow tube down the middle, and it can be a little bit claustrophobic. The MRI basically uses magnets and radio frequency pulses to create the images. There's no radiation associated with it. And the big advantage of MRI for assessing bone and soft tissue tumors is what's called contrast resolution. So basically what it does is it gives us really excellent detail on the margins of where the abnormal tissue ends and the normal tissue begins, as opposed to CT, where it's harder to tell within a muscle where the tumor ends and the normal muscle begins. So it's really good for preoperative planning and to see how big the surgical resection needs to be. It's also good for follow-up in terms of looking at treatment response if you're having chemotherapy or radiotherapy, to look for measuring the size and looking for necrosis, which we'll come on to again, but also for surveillance imaging. Each set of images is acquired separately. So we talk about a bundle of images as a sequence. And typically an MRI that we would do for sarcoma could have between like 12 and 15 sequences. So this is why an MRI scan takes a little bit of time. It can be between 30 and 45 minutes. They are getting shorter with the improved technology, but it's much longer than a CT. The other really important thing, so people always go, well, you know, CT has radiation, MRI doesn't. Why can I not just get an MRI instead? MRI is not good for looking at the lungs. So anything that has air in it, MRI is not helpful. So with sarcoma, the most likely place for it to spread is the lungs, so we need to use the two together. Claustrophobia is a bit of an issue. We do give sedation if it is needed, and it can be a little bit noisy as well, so we also give headphones. The really important thing is that it's trying to stay as still as you can, because if you do move, if there's a lot of breathing, it can make the images very blurry, and it does make it a little bit harder for us to interpret the scan. There are some people who can't have an MRI, so the classics were always patients with pacemakers and patients with aneurysm clips. A lot of the newer pacemakers are now compatible with MRI. We just need to get the model number. And so pacemaker does not necessarily mean these days that you cannot have an MRI. People always think as well that if they have metalware in them, so like for example, a hip replacement or a knee replacement, that they can't have an MRI. That's not true. You absolutely can. It doesn't interact with the magnet. The only issue with having metalware is if we're imaging near the metalware. That can cause artifact on the scan and make it a little bit trickier to interpret. So just having a look, this is a slice of an MRI of the upper arm. So this is the subcutaneous fat here, and this is the muscle, and this is the bone here, the humerus, and this is the marrow in the middle of the bone. And so what we see is we have this lesion here, and we can see it's very well defined. I could take a pencil and draw all the way around it. But what we also see is the signal in it is quite bright. And we look and see, well, what else on this image has that same signal? And it's the same signal as the fatty marrow in the bone, and it's the same signal as the subcutaneous fat. So this tells me that this is a lipoma. So there are no concerning features, it is benign. Then we have another lesion here. So again, this is their flanks, this is their kidney, this is their lower ribs, and then there's this lesion here. Signal in it that looks like fat, but it's not quite as simple as the lipoma that we have over here. But that being said, it's very evenly distributed throughout the lesion, and there's not areas of fluid, there's not a discrete area that just looks completely different. So this is what's called an atypical lipomatous tumor. And so MRI is really helpful to us to distinguish between lipoma and ALT, which is where ultrasound might struggle. But then if we have a look at this lesion here, so this is another MRI. So this is the whole lesion here. So we can again see we have areas that are bright, that are similar signal to the marrow, and they're similar signal to the subcutaneous fat. So we're happy that this is fat. However, where this asterisk is, this looks very different. It doesn't look like the muscle, it doesn't have the little marbling. And then when we look on these other sequence, we can see it's a very different signal to the rest of the muscle and to the fat. So this is not fat, it is not muscle, it's not fluid, this is a liposarcoma. So this is where MRI is really used, is to distinguish the different components of a lesion. And then, for example, if we were to go and biopsy, we would make sure that we would target this area and not just the fat. So that is why MRI is really helpful. Then we have a look at CT. So CT also has a very important role to play. So less claustrophobic because it's more of a donut rather than a tube, and it's much, much quicker. It's still really important to stay as still as you can. If you need to hold your breath, the radiographer will let you know. And the main reason with CT is it uses radiation. So the radiation passes. So if we go back to the previous image, it goes from one side of the circle through the patient into the other side to hit the detector. And the amount of radiation hitting the detector on the other side will depend on the density of the tissue that it passes through. And then from there, it can work out the different density of the tissues inside you and create an image. Understandably, there are often concerns with people having multiple scans. They get a bit concerned about radiation. The newer scanners are using much, much lower doses of radiation than previously. And we also have to remember that radiation does occur naturally in the environment. As radiologists, it's also our role to make sure that patients are being scanned appropriately and that they're not getting a CT for the sake of it, or that we don't deem that it's excessive. So if we think maybe an MRI would be more helpful instead of a CT, we will change it to an MRI. But CT is excellent for certain things like looking at the lungs and for staging. So it's just a very important part of our imaging protocol. So this is just a little image just to kind of remind you about radiation in the background. So there's a very tiny dose of radiation associated with eating a banana. A flight from New York to Tokyo round trip has 20 times the amount of radiation than a chest X-ray, but people would never think about radiation when they get on a plane. So living at sea level for a year, same radiation dose as a CT head or a CT chest. So it's just to kind of put it in perspective that yes, there is radiation used, but it's used for a very important reason and we limit it only as necessary. So the advantages with CT, it's obviously very quick to perform. And the thing with this, why it's quicker than MRI, is we often just get the one data set. So the patient passes through the scanner once or twice. And then what we can do is we can reconstruct the images at different angles. We can put different filters on them. So we can put a soft tissue filter to look at the organs. We can put a lung filter on to look at the lungs, and we can put a bone filter on to look at the bones, all from one set of images. Whereas we can't do that with MRI, we have to do different sets of images. So that's the reason that the CT is so much quicker. So the main role with CT is that it's used for staging, so assessing for the spread of the tumor to other sites. So while MRI had excellent contrast resolution, so distinguishing between the margin of the abnormal tissue and the normal tissue, the advantage with CT is it has excellent spatial resolution. So spatial resolution refers to the ability of it to distinguish two small structures right beside each other. So basically we can see with very fine detail. And that becomes really important when we're looking for things like lung nodules or little subtle bone lesions. And again, in addition to ultrasound, this is also used to guide biopsy. So there's CT and then there's PET-CT. So PET is positron emission tomography, and so that's a bit of a convoluted term. So positron is a little radioactive particle being emitted, and then this is the type of scan. So the idea with this is that tumors, in addition to, say, things like your brain, your lung, or your brain, your heart, and your liver, use a lot of sugar. They're very active metabolically, but so are tumors. So the idea is we inject glucose, but we attach a little radioactive tracer to it. That gets taken up by the tumor, and then it shows up on the scan. And it gives us an idea basically about the activity of the tumor. So not just the size, not just its relationship to the surrounding structures, but how active that tumor is. The problem with it, though, is these images are really blurry. So where a regular CT scan has excellent spatial resolution, a PET is very blurry. So what do? We combine it with the CT to get more accuracy. So these are the images that we get. So this is the PET portion here. So you can make out that it's a person, but it's very hard to get any real detail. It just looks like lots and lots of blobs. But here again, we can see lots of uptake in the brain because the brain is using glucose all the time, lots of uptake in the liver, and then it gets excreted out the kidneys and into the bladder. We perform a CT at the same time, and then we merge the two together, and then we can get a much clearer detail about what's happening. The other thing that it's really good for, in addition to baseline imaging, is follow-up imaging. So if patients have had radiotherapy, for example, to a tumor, and we want to see if the activity in the tumor has decreased, we can compare the amount of uptake of that glucose between the scans. So if we just have a look here, this is a patient's thighs, and this is their femur and their thigh bone. So this here is necrosis, or basically dead cells. So this is the whole thing here is the tumor, but the central, quite large portion of it is dark, and it's not showing any brightness like we saw on the other scans. So this is areas of tumor that have died. However, we do still have this bright bit here, and this is the bit that's still active tumor. So it's just very important for the surgeon, if they're going to operate, to know where the active tumor is, but also how a patient has responded to the treatment. So just looking at this case here, so this is a patient's distal femur and their knee. So if we just look at the top row of images, so this is the mass here. So this is a Ewing's sarcoma. So we can see on the initial PET scan, it's showing some increased what we call tracer uptake. So it's taking up more glucose with the little radiopharmaceutical attached to it than the tissues around it. They undergo chemotherapy, and then we repeat the scan, and you can see not only has the tumor significantly reduced in size, but also the activity of that tumor has reduced as well. It's no longer creating new cells. They underwent surgery, and then it showed that 95% of the tumor was dead. So that's really helpful information for the surgeons when they're going in to operate. And then I'm just going to talk a little bit about biopsy. So I think this is one thing that tends to cause a lot of anxiety among patients, and understandably so. And speaking to our nurses, the two things they get asked most frequently about: pain, understandably, and when do I get my results? So we'll work our way through. So as I mentioned, we can use ultrasound or CT to help us guide our needles. The superficial lesions, the ones that we can feel under the skin, or that may be a little bit deeper, but we can see them on ultrasound, we do it under ultrasound. Anything that's deeper and we don't see it well with ultrasound, or if it's a bone lesion, we generally do those with CT. They are really well tolerated. People think that maybe they're getting some kind of a surgery, but the vast majority of people come out and say that's nothing like I thought it was going to be. It was absolutely fine. I think it's the anticipation of the pain. It's not really knowing what to expect. So I'm just hoping these next few slides just maybe give you an idea of what you might expect if you're having a biopsy. We don't use general anesthetic very rarely. The only time we would really use it is in pediatrics. We do give sedation for mainly the CT procedures, because they do take that little bit longer, because we have to pop in and out of the room. And then once we take the samples, we send them to the pathology department at Middlemore, and then we discuss the results at our weekly meeting. In terms of the results, we can't really tell you when you're going to get them. It varies depending on how busy the lab is that day and whether or not. So if it's something very straightforward and they only need to do 1 or 2 tests on it, they'll come to the results very quickly. But if it's something a little bit more complicated, maybe it's something quite rare, or they're waiting on specialist tests, it can take a little bit longer. So that is why it's very difficult for us to tell you when the results are going to become available. So what to expect when you're getting a biopsy? So the vast majority of these are done as an outpatient. So if you come to Auckland Hospital, you will come to our day ward, where you'll be met by one of the nurses, and you'll be admitted onto our little ward. There's about 8 beds. And when we're going through the consent process, please ask as many questions as you like. That is what we're here for. There's no such thing as a stupid question. If you're asking questions and you're not understanding something, it means I haven't explained it clearly in a way that you understand. It's on me to explain it in a way that you understand. So keep asking the question until you understand what's happening. The other thing to remember is, just once you sign the consent form, that doesn't mean you can't ask any more questions. Please feel free to continue asking questions throughout the procedure. It's always important to know what's happening, what to expect if you're going to feel something sharp. So at any point during the procedure, you can always ask questions, because it is sometimes hard when you're put on the spot and then it pops into your mind halfway through. Ask away. In terms of positioning, obviously it does depend on where the lesion is, but we will try and keep you in a position that's as comfortable as possible, because we want you to stay really, really still. So it's really important at the beginning of the procedure that if it's a position you feel like you can't hold, you need to let us know, and we'll work around you and what you can hold. So what we do is we identify the site, and if you're in ultrasound, we will do a quick ultrasound scan first, and we'll just mark a little spot over the skin where we're going to do the injection. We'll clean the skin with antiseptic and then give you lots and lots of local anesthetic. Okay, we do loads and loads of numbing, and there is no limit on the amount of local anesthetic that you can get. Okay, so if I put in some local anesthetic and then you're like, no, that still feels a little bit sharp, we put in more, and you just let me know, because everybody is different. And then what we do is we make a little incision in the skin, just a few millimeters. And with the probe over the lesion, we guide the needle into the lesion. And the advantage being that means we can be very specific about what part of the lesion we're targeting, and also make sure that we avoid any structures around the lesion that we don't want to hit. So things like blood vessels. With any procedure, once you cut the skin, there's always a tiny, tiny risk of infection and a tiny, tiny risk of bleeding, but we can always manage those if and when they happen, but it's like 1 in 1,000 for infection. And then the bleeding risk will depend on where we are in the body. And generally what we do is we take multiple samples. Okay, so as I mentioned, the pathologists like to do multiple tests. just to make sure they're absolutely clear on the diagnosis. So the more material that we can give them, the better. Sometimes, depending on the nature of the lesion, they might not have enough material and we may have to repeat the biopsy. So to minimize the risk of that happening, we will take several pieces. So when we take the biopsy, if it's in under ultrasound or if it's a soft tissue biopsy, the needle will make a little bit of a clicking noise, kind of like a snapping of the fingers, but you won't feel it, you will hear it. So it's just to be aware of that. Under CT, it's slightly different. So in ultrasound, we're there beside you in real time from start to finish. With CT, because there's radiation and we're scanning you, we tend to step out of the room as we check the position of the needle. So we will place the needle in under the skin, direct it towards the lesion, take a picture with the scanner, check our position, and then make any adjustments as we advance the needle towards the lesion. And what we do is we advance it to the edge of where we're targeting. And the needle has an inner core that we can take out. We leave the outer core in place, and then we pass another needle down through it into the tumor and take our samples. If it's a bone lesion, we use what is essentially, and I know this is going to sound a little bit scary, but essentially it's a bone drill. And it does make a noise like a bone drill. But again, it's a feeling more of pressure rather than pain, because we will numb up the bone before we go into it. And again, at any point, if you need extra numbing, if you need extra pain relief, we often give sedation for the bone lesions. I will often judge if I need to give you extra, but if you feel like it's very uncomfortable, we can absolutely give you more pain relief. Afterwards, what we do is there's a little nick on the skin. We'll usually put maybe some paper stitches on and a small bandage. And usually we will keep you for a little while afterwards. We just want to make sure that your blood pressure is okay, that your heart rate's okay, because people are obviously often a little bit anxious. And also just make sure that there's no bleeding at the site of the biopsy. So if it's a CT biopsy, usually about 1 to 2 hours. If it's an ultrasound biopsy of something superficial, very straightforward, maybe half an hour to an hour. So this is an ultrasound biopsy. So just before I hit play, this is the lesion in here, and then you'll see a white line coming in from the right, which is the needle coming in. So this allows us to basically pass the needle into the tumor and take the sample while seeing the tumor in real time. So it just means we can be really, really confident that we're in the tumor and not just beside the tumor, but also that we're targeting the right part of the tumor. But you can see here how close this is to the skin surface. If it was further down, we would really struggle to see it, and that's when we might decide to do it under CT. So everything is decided on a case-by-case basis. Oopsies. There we go, CT biopsy. So this is a MRI of a distal femur, so the thigh bone. So we can see here that there is a tumor in the distal femur. And so because it's in the bone, this is one where our ultrasound won't see bone. So we will do this under CT. So what we do is a planning scan. So the patient will lie in the position that we will find easy to get access to. And we will often discuss this with Andy or one of the other surgeons as to what path they want us to take, so that we don't interfere with any potential surgeries down the road. So we stick this sheet that has these lines on it. And so when we do our scan, they show up as dots, and then we can do our measurements. So we've drawn a line down through the bone, and this is the tumor in here. And then this is the image here of the biopsy needle going through the cortex and into the tumor. So usually what we would do is we get the outer needle, which is the bigger one, just inside the cortex, and then we would take multiple samples. We angle the needle and take multiple samples through the bone. And so just as a final note, I just wanted to say that just by being here at the webinar, or even just by watching this at a later date, you have made a choice to contribute to patients becoming more empowered in terms of managing their own health. So I just wanted to say thank you very much for doing that. A big part of this is just encouraging patient education. And so the more you understand about what's going on with your health and your body, the more you can advocate for yourself and then contribute to the decision-making process with the sarcoma team. And we are here to help. I know as radiologists, we will not probably see you nearly as often as you might see Joanna or Andy. You might only see us for the biopsy and never see us again. But please feel free to ask us any questions you like when you do see us. And just remember, every patient is different. We will tailor our care to you, we tailor our scans to you, and we tailor our biopsies to you. Thank you.
Very much, Karen. That's fantastic. A really good and comprehensive going over of the radiological involvement in the service and what patients can expect. So I'm really grateful. Got a few questions, if that's okay.
Yeah, sure. Hopefully I can answer
that. So I guess these are broad ranging and over the topics you covered, and you covered one that I thought would be very pertinent, was about the dangers of imaging, and you covered that off quite nicely with your picture. How do you know which is the best imaging technique to use?
So again, we will very much tailor it to the patient. So it very much depends on the clinical information that we are given. So we rely on a history from the referring doctor. So if the doctor is telling us that, for example, they can feel a soft tissue lump and the ultrasound has shown a mass, I will go, yes, that patient needs an MRI. If, for example, the patient is saying they have they've got some low back pain and they have some a history of a particular disease. So it all depends on their clinical history and their blood tests and also their previous imaging. So it's based on the history that we're given, but oftentimes as well, it's multiple. So we might have to do a CT and an MRI. But for sarcoma, for bone and soft tissue, it'll always be MRI as a baseline.
Okay, thank you very much. Is there often, and I guess Joanna probably is the same, when we see patients in clinic, they may be fixated on something like PET scan being the best thing you can have. Mm-hmm. Is there one particular best, gold standard imaging, or is it just different?
No, yeah, I suppose MRI is definitely the one that we use the most in terms of looking at the primary tumor. PET scan definitely has its role, looking, like we said, at the activity, but it doesn't offer us the soft tissue detail. So every imaging modality, going right back to the basics of an X-ray, has its own advantages and has its maybe sort of slight shortfalls. They all work together, and so we use all of them. So don't think that, well, because somebody else got a PET scan and I didn't, that therefore they're getting more in-depth imaging than I am. We very much tailor it. It's on a case-by-case basis, and we would never do a scan on somebody unless it really needed to be done, and if it was going to answer the question that we want answered. Okay,
thank you. How do you know where to biopsy? How do you know what part of the tumor to target? Is there a way that helps you with that?
Yeah, so again, we often rely on the MRI, and we will discuss it with the surgeons. So we look for areas that look, so when we do a scan, we will often give contrast. And what we want to basically biopsy is the area that's enhancing, which tells us that it's got a good blood supply. So that's going to be the area that's more active in the tumor. Because if we biopsy the area of necrosis, which is the dead tumor, that won't give the pathologist the answer. So we want to target the solid enhancing part. So we will look at that in the MDM, pick the part, make sure everybody is in agreement, and then we discuss with the surgeon what is the best approach to get to that enhancing part.
Perfect, thank you very much. And somebody just asked if when should a doctor be sending someone for a biopsy? When should my doctor be sending someone for a biopsy?
Yeah, so we generally say we don't necessarily take the GP doesn't need to make that decision, I'll say that. So the GP is really important in terms of making the decision to refer to the sarcoma service. We will only make the decision to biopsy once we know there's something to be worried about. So to do that, we need to have the MRI first. So what we do is, if the GP is worried and thinks something might need a biopsy, they contact the sarcoma service. Oftentimes the MRI will get arranged very, very quickly. And then we will discuss the MRI at the meeting and then decide if it needs the biopsy. So the GP doesn't need to make the decision. We can help make that decision for them.
Okay, thank you very much. Thanks very much, Karen. That was fantastic. And as always, this will be available on the Foundation's YouTube channel for anybody who wants to come back and watch it, or if you've got someone you know coming up for a biopsy or scans, then please direct them to the website. Thank you very much, and thanks, Karen. I'll hand back over to Joe.
Oh, thank you both of you. I hope everyone listening tonight and then online later will find that helpful. July is Sarcoma Awareness Month, so we'll be planning lots of things to promote awareness and education and offer support in that space. So as always, stay tuned, and we really hope you could support us in Sarcoma Awareness Month, July 2025. For now, good night, and see you all again soon.
Thank you.
Thank you.